Hello everyone. Today we will be presenting the various aspects of the colorectal cancer. So as we know, colorectal cancer affects the large intestine. In the picture shown, we can see the different parts of the large intestine, which includes the cecum, the ascending colon, the transverse colon, the descending colon, the sigmoid colon, and the rectum. So the cancer which affects in these areas are called the colorectal cancers. It is the third most common cancer among males and second most common cancer among females in the world. In India, it is the fifth most common cancer, and the incidence of colorectal cancer is on the rise in India. So now we will look at what are the various symptoms with which a patient can present to our OPD. So the common symptoms include blood in stools. When the patient is passing stools, there may be presence of blood in it. There can be altered bowel habits, which may be constipation, which is difficulty to pass motion, or diarrhea, which is increased frequency of passing motion. There can be abdominal pain, which can be in the entire abdomen or in one particular part, like the lower part of the abdomen, or it can be maybe a discomfort. There may be an unexplained anemia, which is a drop in the hemoglobin without any possible other explanation. There can be a weight loss. The patient may experience a weight loss which may be quantifiable, or he may report symptoms like the shirt is becoming loose, the pant is becoming loose, etc. Then we also have to look for the other risk factors, which may include the hereditary colorectal cancer syndromes like familial adenomatous polyposis Lynch syndrome, MUTYH associated polyposis syndrome, etc. These are to be asked in the family history. The patient may also report a history of certain inflammatory bowel diseases like ulcerative colitis, Crohn's disease, etc. So in the history, we have to take a detailed history for these suggestive symptoms. The examination is carried out next, which includes general examination as well as a perabdominal examination. The perabdominal examination looks for various lumps or any hepatomegaly, any splenomegaly, or any other palpable tenderness, etc. A perrectal examination is done to look for any mass lesions in the rectum which may or may not have bleeding associated with it. Systemic examination is done to look for other areas of spread where the cancer can metastasize, like for example the liver, any lymph nodes, into the lungs, into the bones, etc. So we have the systemic examination is done specifically to look for these areas of possible spread. The next part comes the blood investigations, which includes a complete blood count. In this we look for any drop in hemoglobin, a liver function test where there can be an alteration if there are any liver metastasis, a renal function test where urea and creatinine are generally done. These tests also help us to assess the fitness of the patient for chemotherapy. The tumor marker which is generally used in colorectal cancer is called the carcinoembryonic antigen. It may be significantly elevated in a majority of the cases. The next step would be colonoscopy, where a camera is inserted through the anal opening, which can be traversed up to the end of the large intestine, up to the cecum, and the entire area can be visualized to look for any ulcers, any ulceroproliferative growths, etc. Also, another advantage of the colonoscopy is its ability to take a biopsy, which can be submitted for histopathological examination to know the nature of the tumor. The next step would be radiological investigation. We have to know how far the cancer has spread in the local and the distant areas. So for that we'll do a CECT, contrast enhanced CT scan, which involves the chest, abdomen and the pelvis. The microscopy which will be submitted for the histopathological examination will tell us the nature of the tumor. Then the next step would be the investigations to assess the operative fitness, which includes an ECG and echocardiogram to assess cardiac fitness, a pulmonary function test and chest x-ray to assess the lung fitness of the patient. A molecular testing can be undertaken on the biopsy specimen, which includes MSI, KRAS, BRAF, HER2, etc., which are various mutations that can be seen in colorectal cancer. A genetic testing for relatives can be advised if there is significant family history of the patient. In the pathological examination, we look for the size of the tumor, we look for the nodal status of the tumor, what is the immunohistochemistry of the tumor, and if there's any presence of other components like lymphovascular stromal invasion, etc. So based on this, we can assess the stage of the disease. As we can see, if it is tumor 1 or tumor 2, T1, T2 stage, it is called a stage 1 disease. If it is T3, T4, it is called a stage 2 disease. If there is nodal involvement, it is called stage 3 disease. And if there is spread to the other organs, that is distant metastasis, it is called stage 4 disease. The ultrasound of the abdomen is often the initial investigation, which will be followed by a CT scan, which will help us to assess the local as well as the distant stage of the disease. It is generally undertaken for the chest, abdomen, and the pelvis, which will also tell us the extent of the spread of the disease. A PET scan can also be substituted for this. Coming to the treatment part, the various surgeries which are undertaken for a colorectal cancer include total colectomy, hemicolectomy, and diversion colostomy, which is done as a temporary procedure. The chemotherapy options which are generally administered are FOLFOX, which is the abbreviation for 5-fluorouracil, leucovorin, and oxaliplatin. The capecitabine oxaliplatin regimen, which is called the CAPOX regimen. Single agent capecitabine, which is also very beneficial drug in colorectal cancer. Targeted therapy options include bevacizumab, which is a VEGF antibody, and cetuximab, which is an EGFR monoclonal antibody. The immunotherapy options which are generally used include pembrolizumab and nivolumab. So the response is assessed based on clinical improvement, reduction of the carcinoembryonic antigen, scans which may show response, disease response. So the follow-up will usually be done using a detailed history to look for any recurrence of the suggestive symptoms. A perabdominal and perrectal examination will be done, and serial follow-up of the carcinoembryonic antigen values. If there are any symptoms, the scans will be undertaken, which includes a CECT of the chest, abdomen, and pelvis. In case of there's a progression of the disease, retreatment is done in some of the patients who are fit. The various treatment options at a case of relapse include the same or different chemotherapy, like the FOLFOX single agent capecitabine or any monoclonal antibodies. Resurgery, chemotherapy, targeted therapy, immunotherapy are the various options which can be used at a relapse setting. The various toxicities of the treatment includes diarrhea, which can be seen with 5-fluorouracil, vomiting, which can be seen with drugs like oxaliplatin, fever or infections, which can result as a result of febrile neutropenia. Because of the neutropenia, the infections can set in. Patients can have tiredness, fatigue, loss of appetite, etc. 5-fluorouracil is known to cause a rash in the hands in a syndrome called hand-foot syndrome, which generally present with painful rash in the hands and the feet.